Welcome to the webinar, Exploring Spirituality and Religious Beliefs with Patients. Hi, I'm Barbara Lewis, the Managing Editor for .com, an online communication skills learning system for medical schools, residency PA and NP programs, and hospitals. Now that .com offers over 40 CME credits. Joining me today is Dr. Stuart Sprague. He is the author of .com's Module 19, Exploring Spirituality and Religious Beliefs. Welcome, Stuart.
Thank you so much. It's a pleasure to be with you.
Well, thank you. Tell us a little bit about your background.
Well, I taught religion and philosophy at an undergraduate school for a long time, and then I entered the hospital and the clinic as a faculty member at a residency program, and I've been doing that now for full-time for about 20 years. I focus mostly on behavioral medicine, medical ethics, humanities, communication skills. I just today finished an elective clerkship with a medical student who came, spent a month with us to do a religion and medicine elective, and that's been a very productive part of my work in the last several years.
Wow, that sounds very interesting. So let me just tell our listeners a little bit about the webinar. It'll last about 30 minutes, and a recording and the PowerPoint will be available on the .com website shortly. If you have any questions, you can type them into either the question box or the chat box, and that's located on the side panel. And if we don't have a chance to get to your question during the webinar, we certainly will respond afterwards. So let's get started. Stuart?
Okay, very well. We have some learning objectives for the webinar, which are the first slide, I think, so we can go to those.
Okay, you should be seeing the learning objective slide. Do you see it?
It hasn't appeared on my screen yet.
Okay, let's see. If we could just have somebody in the audience tell us whether or not they can see it.
There we go. It just appeared.
Okay.
So the learning goals for this experience are to be, at the end of the time, to be able to describe a rationale for exploring and supporting the role of religion and spirituality in patients' lives, to have the ability to ask patients about the importance of religion and spirituality in their lives, to explore whether patients' religious beliefs give meaning and support to them in their experience of serious illness, suffering, and death, to offer patients religious and spiritual support, such as referrals to clergy, and also to anticipate professional boundary violations with respect to religious and spiritual matters so that those can be avoided and we can always have productive conversations with our patients. So let's go to the next slide. And I'm still not seeing.
I apologize, Stuart. There seems to be a big lag between when I'm changing slides and when you're actually seeing it. Usually it's not this long.
No problem.
You should see key principles.
Yes, I see them now.
Okay.
There are several key principles at work in this practice or this activity. The first is that religion and spirituality are important to many of your patients. There is good literature out there about the extent of the population's involvement or reference to religion and spirituality in their own lives. And when you explore this role of religion and spirituality in their lives, this is usually helpful to them. When patients make meaning of their medical condition in religious terms, this can have positive as well as negative consequences for their well-being. And you'll notice if you've done the module on .com regarding spirituality and religious beliefs, there is a video that talks about or gives an example of a patient who had some concerns about the negative consequences of her religious beliefs and her feeling judged and having issues and questions about that as she experienced her cancer and her illness. So when patients make meaning, it can be in a positive and a negative way for them. A fourth principle is to clarify patients' religious interpretation of their suffering, and this may help you offer additional support. And it's not up to the physician to do all the work in this particular area. There are other professionals in the healthcare environment who have expertise in these areas. And part of your role as the physician may be include referral to an expert who has the time and insight to help the patient work through these kinds of things. I've even known of folks in outpatient practices who had either counselors or clergy or others who were readily accessible to their patients, and they could make appointments and make referrals to these folks. And this was a great help to their practice of outpatient medicine. Obviously, in the inpatient side, many hospitals have chaplains and others who are available for referral as well. The last principle is to never impose one's own spiritual beliefs on your patients. The idea is that there is a power differential in the relationship often, particularly between physicians and patients. And this shouldn't be a basis for using that power to influence or impose beliefs and ideals on patients. We want to focus upon their understanding, their interpretation, and their own application of these issues to their understanding of their illness and how it affects them. So we never want to impose beliefs on the patients. So let's go to the next slide.
It's up on my screen.
I make some important distinctions in my work with medical students and residents as well. And I realize that sometimes distinctions are thought to be just a matter of semantics, but in my case, I really think that there are meaningful differences in the way in which we use words such as these. And so I think it's important to choose words, to choose language that speaks specifically to the issues in the life of the patient. The first one that I use is my own distinction between disease and illness, and there are others who do this. This is not unique to me. A disease is a pathological process that's taking place in my body. There may be pathogens that have been introduced. There may be organs that are not functioning properly. And this is the classic role of physicians and other healers, is to identify those pathologies and to intervene to try to stop them or eliminate them. On the other hand, illness is a more social description. It is an experience that one has when a disease is taking place in my body. And that often has life-changing implications. It can be a chronic illness that will determine that I will have to deal with this for the rest of my life. My life will be limited in some ways because I will consistently have to check my blood sugar, be careful about my diet, other kinds of things. I had a patient visit with a gentleman just last week, and he had had an amputation, and his life was restricted or circumscribed by this amputation because he was not able to be as mobile and to be as part of the community as much as he had been before the amputation. And so often diseases will lead to implications that have serious changes and impacts on one's life, and illness could be a way of describing that. The second distinction I make, and it's also made in the videos on the .com site, there's a difference between curing and healing or caring for patients. Curing is eliminating the pathology that causes disease, and some diseases can be cured, others can't be cured. And so we have to be very careful in our description of this to the patient. Is your disease curable? And if so, what will it take for us to go through that process together to lead toward a cure? Or is curing not an option here? That is, the disease can't be cured, but we can also always heal the patient. Healing, I say to my residents and students, is the process of moving to a better state. Regardless of whether my disease has been cured, I can be healed. And I can be better over time. I can be in a better place and have a more positive view toward life, a greater sense of meaning and purpose. I can accept the limitations that my disease impose on me and live within those boundaries, whereas prior to this I might have been depressed or concerned or morose, if you will, not feeling well about myself. And so to be healed would be to move to a better state. Sometimes the disease improves, sometimes it doesn't, but one can be cared for. And the role of physicians and healthcare providers is always to care for patients, even when they can't be cured. The third distinction I make is between religion and spirituality. Religion is the more visible outward elements of participating in a community of faith. It can be worship, it can be ritual, it can be supportive relationships, it can be social action, other kinds of things. These are all activities and benefits of being a part of a religion, and they are to some extent identifiable, maybe empirically observable, and we can put our fingers on, so to speak, the impact of religion. Spirituality is more subjective. It's the inward experience of a transcendent dimension of life. It's looking inward for a sense of meaning and purpose. It's looking toward a transcendent being or God for many. There are even spiritual dimensions, I suppose you could say, for those who don't specifically have a deity in mind. They may think of the world as responsive to transcendence and a willingness to see the spiritual nature of our human experience. And so those things can play into this healing process that I mentioned earlier, that being spiritually alert, spiritually alive can be a very helpful and healing experience. So I make the distinction between religion and spirituality. There are debates about that among philosophers, but in a practical sense, I think it is a meaningful distinction. So let's go to the next slide. Why is it important for us to do this work of attending to spirituality and religion in the medical environment? The basic reason is that religion is important for a majority of the people in the United States. The text of the .com module has more about that, and some of those citations in the bibliography give you the data that show that religion is important to a majority of people. Actually, there's also a body of research that shows a correlation between participation in spiritual and religious activity and positive physical and mental health outcomes. There are two large volumes called the Handbook of Religion and Health that have come out in recent years, and these have hundreds of studies about the relationship between spiritual and religious activity and physical and mental health outcomes. And so this is a growing body of literature, and I think it tells us that it's important for us to be aware of it and use it as part of our tools of taking care of patients. Another reason is that one of the things that has been shown in this research is that patients would actually like, many times, for their physicians to incorporate these concerns into their care. It's not 100%, and I think we'll talk in a minute about one of the boundaries, but it is probably a majority, and many of them are reluctant to raise that directly with the physician, saying, would you please do this? They demur, they hold back, they feel that they shouldn't tell the physician how to practice necessarily. But quietly or secretly within their own minds, they say often, I think, gee, it'd be interesting or helpful if my doctor would ask me more about that or incorporate that into what we're doing together to take care of my diabetes or whatever other illness there is. The other thing is that good patient interviewing includes a holistic approach to the patient, and that the biopsychosocial model tells us that there are many aspects of patient reality that have a bearing on their physical health, and this includes the mental, emotional, and spiritual roots and influences on the experience of illness. So a good holistic, well-rounded interview that includes a spiritual and social history is in keeping with good medical practice in that regard. And there are a number of folks doing work, and obviously .com is one place where a lot of that's done, where we're showing that interviewing involves this holistic approach. Now, if you decide to do that, then there are certain skills that come into play in doing that well. One skill is the ability to do a non-judgmental exploration of the spiritual and religious beliefs of your patients. The key is that it be a non-judgmental experience. Those who go into the experience with preset notions of religious or spiritual beliefs and let those influence the way in which they ask those questions or the way they respond to what the patients tell them could be counterproductive. And so you really have to be non-judgmental. I think it's a key to being an open-ended question, or I say often to my residents, the most important tool in the doctor's bag is the open-ended question. And so that's true here in this exploration of spiritual and religious beliefs. Another skill is specific inquiry at the times of suffering. There are ways in which you can begin a general inquiry about the illness and how it has impacted their lives, and then move to ways in which this interacts with specific religious beliefs and practices. I do a number of home visits, and often I will be in the home of a patient and I'll see a picture on the wall or a figurine or something, or Bible on the table or something like that. And that tells me that even though we may not have talked about it up till then, this patient may have spiritual and religious beliefs that if we were to ask the question and open that part of the conversation, it might be productive for us. So being specific about it, and particularly around times of suffering where the religious beliefs of the patients may be at work in their experience more actively, don't be afraid or hesitate to ask those kinds of questions and make those connections. The third skill is to demonstrate understanding and respect. Invite the patients to dialogue. Don't make it a one-way street. As we say, we have one mouth and two ears, and so we should listen twice as much as we speak. And often that's a very useful way to approach the subject of religious beliefs. Pay attention to the context and the relationships and the nonverbal signs. Some of the videos that are part of the .com module also demonstrate using these tools or these skills as you make the inquiry and get closer and more information from the patient. And then fourth, to suggest and offer help. After you have trust, then clearly you may direct them to other resources that are available. We have an especially active chaplain at our institution. She's a wonderful resource, and my students and residents enjoy working with her on a rotation or a one-day visit to her. And she shows them many different ways in which she can be a resource and a help in caring for the patients that they share. So that's something to do as well. One of the ways of doing this is to, quote, take a spiritual history. And there are a number of acronyms, a number of articles that have been written about how to take a spiritual history. There are several mentioned in the bibliography that's attached to this PowerPoint presentation. I'm going to mention one of them because it is probably the most actively used. I don't have data about that, but in my experience, this particular acronym is one of the most widely used. The others are very similar, to be honest. They ask similar questions, and so by focusing on this one, you'll get the best of how to do this. The acronym is FICA, and the letters stand for faith, just a kind of introductory inquiry. Do you have faith? What is your faith? Tell me about your faith. And that leaves an open-ended way for the patient to respond to your initiative. And if they take your invitation, they may want to talk about it. They may say, I don't have faith, and they may say, I'd really rather not talk about that. And if so, you can respond appropriately to that. But this little entering technique of asking about faith is one way to get it started. Once they have said they have a faith, then you can say, how important is this? What role does it play in your life? Is it something that you just kind of remember from childhood, or is it something you're actively involved in as an adult? How important is that faith? The C is for community. Are you a part of a community of faith? How does that work for you? Do you find support and reassurance in your community? People who help you through your hard times or your difficulties with your illness. And the A is for application or address. How would we apply these insights, and how would we address these issues as I help you take care of your disease or illness? How should we address these in your medical care? And so that's a kind of a quick, short, it doesn't take a lot of time, and obviously it gives the patient the opportunity to accept or to, in some cases, perhaps reject your initiative into their spiritual life. The boundaries, when you're addressing these issues, you're in very complex territory. And I think it's important for the clinician to have a sense of comfort with this and with the issues that come up in the conversation, a sense of competency or a feeling that one can actually deal with these and make them into a useful tool for the care of the patient. So don't go beyond where you feel competent and comfortable. It'll be clear to the patient that you're uncomfortable if in fact you are. So be aware of and sensitive to your own sense of competency here. The second boundary is to follow the patient's lead rather than your own agenda. We do have patients who ask for their physicians to pray with them or pray for them. I would suggest just doing those things that you feel generally comfortable doing. If you're not comfortable, quote, praying with them or for them, you can simply offer to be silent and let them say the prayer or verbalize the concerns that they have. And that way you're participating with them, but you're not asked to, quote, make your own prayer or do your own thing, which would not be inconsistent with your own religious beliefs. Excuse me, I've had a virus for a few days here. I would avoid spontaneously saying, gee, don't you want me to pray with you, in a sense like that. I would check for consent. Is it okay if you have the sense that it's a very spiritual moment? And I can look back to several encounters with patients where I felt that it was especially a spiritual moment. And so I said, would you like for us to pray? And I remember one case where the patient, actually it was the mother of the patient, just said, yes, please, that would mean so much to me. And so if you check for consent before initiating your own practice or your own intervention, then that will ensure that the patient or the family member feels comfortable with what you've asked them to do. And then respect what they say. If they say, no, please don't do that, I think we are obliged to just not do that. On the other hand, they may have a specific way or a specific practice that they would like observed or respected, and certainly we have to do that. And the next boundary is just do not use the visit to promote your own agenda or to change the patient's spiritual values. You are in an uneven power relationship, and the patients are vulnerable during this time of illness. They deserve our respect. And so it isn't a time to promote an agenda or try to change or, quote, convert the patient to a particular spiritual belief or value. And so that's a boundary that I think should be fast. Next, don't prescribe religious or spiritual practices. There is one critic of this movement who wrote an article, and he said, We can show that people who are married have better health outcomes, but we don't prescribe marriage to our patients. So why should we prescribe spirituality? And I think we should respect that boundary. It's not about telling people what they ought to do with their lives. It's about helping them to understand where they are and what they do and how they believe and how that plays out, and then how that can be helpful in the healing process. And then again, we've talked about this, use the appropriate resources for referral, and it may behoove you to look up what the resources are. How many chaplains are on the staff at the hospital where you work? Or are there folks in the community who would be willing to be a resource to patients who had these kinds of needs and wishes? Or do you have a relationship with a particular church or group and know something about people in that group who would be helpful to your patient and might connect with them as a resource or a support mechanism or support community for them once they leave the hospital or have a healing experience? Who's going to be the follow-up? It might not be possible for you to do all of that yourself. So using the appropriate resources is always an important skill and a boundary that we shouldn't try to do it all by ourselves. This bibliography is the one I have that is connected with the resources for taking spiritual histories and some of the other things. So I encourage you to use these. I'm happy to receive emails and correspondence from those who would like more information, and even to have some dialogue or conversation about these issues over time. So, Barbara, I think we're through the slides, and I'm coming to closure here.
Yes, this has been very interesting. I like what you said about 2 ears and 1 mouth. Listen twice as much as we speak. I love that.
Right. That's always a good
Stuart referenced .com Module 19, Spirituality and Religious Beliefs, and for more information, you can refer to that. Just briefly, let me tell you a little bit about the importance of communication skills, evidence-based, that they improve good communication skills, improve medical outcomes, decrease malpractice claims, enhance physician and provider satisfaction, and improve patient satisfaction scores. It's been proven that communication skills are what's driving the HCAP survey scores. And there's 2 communication dimensions on those surveys. So just a little bit about .com. We have 42 modules, each about an hour in length. We give over 40 CME, MOC credits, have over 400 videos that are loved by our learners in any surveys that we do. We also have annotated interactive videos and plenty on the back end for faculty resources like assignments, assessment questions, grading matrix, lots of resources. Here's just a sample of what we do. We start with a rationale, key concepts, learning goals. Then we have videos interspersed, a behavioral checklist, and lots of references. Everything is based on research. Our annotated videos here, you can see the clinician is talking with the patient and her husband in this case, and as they're having a discussion on a certain topic, it's highlighted here, and then if you click on the icon, out pops the clinician talking about what he's referring to. Here's one of our comprehension scores. This is where the learner goes through and clicks off where an empathic comment should be made, and this helps people to build their empathy understanding. Here's another comprehension score. The learner looks at the facial expression and then clicks on which one of these 6 it is. And we have, as I mentioned, lots of resources. So thank you, Stuart, so much for talking to us. And thank you to everyone.
Thank you. My students and residents really enjoy .com, so we're glad you're out there doing this work.
It's great. Thank you so much. And thank you to everyone who has joined us today, including our friends in Europe who have joined us. The recording and the PowerPoint will be available on our website shortly. And if you're not currently subscribing to .com, you can get a 1-month free trial subscription with this code WebNOV17. And thank you, everybody. Thank you again, Stuart.
Thank you.